Welcome everyone to the Special Populations Core 2024 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining us for today's presentation focused on racial and ethnic disparities in hospice use. Before we jump in, if you have any questions during the talk, please feel free to unmute and ask. We'll also have some time at the end of the talk dedicated to Q&A as well. It's my pleasure to introduce our speaker today, Dr. Julie Robison. Dr. Robison is a gerontologist, health services researcher, and professor of medicine and public health science in the Center on Aging at the University of Connecticut School of Medicine. She is the director of 2 research cores at the UConn Center on Aging, the Evaluation and Population Assessment Core, and the Recruitment and Community Engagement Core. She conducts evidence-based health services research and intervention studies focused on aging families and long-term services, supports, and policy using quantitative and qualitative research methods. Her research aims to improve quality of life and quality of care for people who need long-term services and supports in either community or institutional settings, and their families. Dr. Robison's research focuses on how long-term services and supports funded by Medicaid, Medicare, and other public sector sources affect health and well-being. Specific areas of expertise include effectiveness of long-term services and supports for older adults and their families, designing evaluations of innovative programs promoting person-centered care and independent living, long-term services and supports for people living with dementia, and health disparities in the populations needing long-term services and supports. The results of her work have direct impact on the implementation of policies and programs that serve extremely vulnerable populations in Connecticut and nationally. She's also the past editor-in-chief of the Journal of Applied Gerontology, an international forum for research with clear and immediate applicability to the well-being and quality of life of older adults, providing comprehensive coverage of all areas of gerontological practice and policy. We are very excited to have Dr. Robison with us today and are so looking forward to this presentation. So Dr. Robison, over to you.
Thank you. Thank you so much, Kylie, and thank you all of you for inviting me and hosting me today. It's great to know about this this organization, and I get to meet a few of you. So as Kylie mentioned, please raise your hand or just speak up if you want to ask a question. I think it will go much better if people are able to get their questions answered as we go rather than waiting to the end. So very happy to make this a discussion format. So I'm going to give you an overview of a paper that we published, my team and I published. It came out in JAMA Health Forum last December. And the title you can see here on the slide was focused on racial and ethnic disparities in hospice use among Medicaid-only and dual-eligible decedents. I'll explain some of these terms. Just a couple of acknowledgements and disclosures to begin with. This is a link to the paper. You can find it, JAMA Network journals here. And Kylie, I don't know if you're planning to share the slides, but that is completely fine if you want to do that afterwards. Otherwise, you can just Google the my name and the article title or parts of the article title, and you will find it. I had a number of co-authors on this paper from the UConn Center on Aging primarily. So Alice Dillon, Deb Mignalt, Dottie Wakefield, Noreen Shagru, and Dory Charles. And we also collaborate with the Connecticut Department of Social Services, and Brad Richards, who's the chief medical officer and basically the medical director of the Medicaid program, is also a co-author on this work. And the work was supported by grants and contracts both from Connecticut Department of Social Services as well as the National Institute on Aging through our Claude Pepper Older Americans Independent Center. Other than those funders, I have no financial disclosures to report. So just give you one slide of background and a little bit of introduction to the study, to the analysis that we did. There's been a good amount of work on hospice and looking at differences in hospice use by race and by diagnosis, but an area that really is ripe for more exploration. We don't know a lot about differences in hospice use by payer source, especially for low-income individuals who have Medicaid insurance coverage. Despite seeing some mixed evidence in the literature on the optimum period or length of time that hospice is used in order to maximize cost savings, we do know that a hospice length of stay of a week or less is considered a marker of poor quality of care of care and is associated with patient dissatisfaction. So with that kind of landscape in the literature and what's known, we worked on this study that I'm going to tell you more about today. In general, and like soundbite overview, we looked at hospice use in Connecticut's Medicaid system, comparing both hospice use and the length of hospice enrollment by payer source. I'm going to tell you more about all of these things, but comparing people who had Medicaid only versus those who had Medicare and Medicaid, so the dually eligible group, and also by race and ethnicity. For Medicaid members in Connecticut who died during a 4-year period and who had at least one of the 5 most common diagnoses for hospice utilization. So a little bit more about the sample and the data source. This data came from an integrated data set of Medicaid enrollment and claims data. So that data comes from the Connecticut Medicaid Management Information System, commonly known as the MMIS, as well as federal Medicare, Parts A, B, and D enrollment and claims, and the chronic conditions warehouse data, which is also CMS data. The study was constructed the sample was pulled that everybody had to meet the following criteria. So they had to be a Medicaid recipient who died between 2017 and 2020, and they had to have at least one or more diagnoses during the 2 years preceding their date of death of certain types of cancer. You can see here on the screen, respiratory diagnoses, just COPD, chronic obstructive pulmonary disorder, circulatory diagnoses, so coronary heart failure or acute myocardial infarction, ischemic heart attack, stroke or a TIA, transient ischemic attack, or dementia, either of the Alzheimer's type or other related dementia. And we chose those diagnoses because they are the 5 most common diagnoses that are related to hospice use. So we didn't have cause of death information in our data. So instead, we used these diagnoses in a 2-year period leading up to the date of death to try to identify people who would have been appropriate for hospice use, rather than people who may have died from other causes that weren't necessarily, that might have been sudden or wouldn't really have been typical for hospice use. So trying to create a sample of people who, for whom hospice use would have been reasonable or expectable, and not looking at decedents from other causes. And then we looked at people who had received Medicare fee-for-service, so traditional Medicare, for all 12 months prior to their date of death, if they had Medicare at all. We also, if they only had Medicaid and no Medicare, they were included as well. And those make up our 2 major comparison groups. But we do not have Medicare Advantage data, so that's a limitation that I'll come back to at the end. So our measures of primary interest, we have 2 outcome measures that relate to hospice utilization, and the hospice utilization information in the data set came from whether or not there was a Medicaid or Medicare hospice claim during the year before death. And the 2 specific measures are whether or not people used hospice at all during that year, and then for those who did, how long they were enrolled in hospice. So that was dichotomized into a short and long stay, short stay being defined as less than 8 days, a long stay being defined as 8 or more days. And then the independent factors or predictors that we were interested in, I already mentioned the insurance status. So to be defined as dual eligible, you would have had that status in any one of the 4 quarters preceding date of death. And the Medicaid-only group was comprised of people who only had Medicaid claims in the 4 quarters preceding date of death and no Medicare claims at all. And then race and ethnicity, we matched our sample to multiple data sources to try to get the best description or best, most accurate race and ethnicity data for people. We used Connecticut Department of Social Services eligibility data. for anybody who might have had a home healthcare episode during the period of time that we had, during these 4 years, we used OASIS data. We used minimum data set for anybody who had a nursing home admission. And then we also used what we call the Connecticut Universal Assessment, which is a standard assessment that's done for people who receive home and community-based services through Medicaid. And we had to do that because the race and ethnicity data is not great in claims data. And so trying to use kind of a hierarchical approach of where the data is considered to be the most accurate, and then filling in and trying to resolve any conflicts to get what we could most accurately attribute to people for their race and ethnicity. We also used age and sex, and then the last independent factor was whether or not people had had any nursing facility utilization within the 60 days preceding death, and that was just dichotomized, yes or no. Any questions about measures or data before I move on here? I can only see a couple people there, so pop your hand up or just speak out if you have questions. And certainly come back to that. Okay, so as far as statistical methods in the paper, we first presented some descriptive statistics about our sample, and then conducted chi-square bivariate analyses comparing different sample characteristics, race and ethnicity, age, sex, diagnoses, and nursing facility stay by hospice use. And then we did separate logistic regression models for the Medicaid-only insurance group and the dual eligible group to examine associations between hospice use and also hospice length of stay and the decedent characteristics. So I'm going to now switch to showing you some of the tables from the paper, and the focus here, this is our table 1, which has the study sample characteristics. This is for the Medicaid-only group, and that group had just over 2,400 people in it. I'll just draw your attention first to the highlighted kind of factors here. These are our 2 hospice outcomes. So in the Medicaid-only group, the decedents, 32% used hospice at some point in the year before death, and 41% of that group had a short length of stay, so that period of less than 1 week if they did use hospice. I'm going to focus here on the numbers that are outlined in red. The other 2 columns compare using hospice or not across the different characteristics, but we also have similar comparisons in the logistic regressions that I'll be showing you later on. So rather than going through that here, I'm going to wait till I'm showing you the regressions, which are adjusted for the other factors. But just in terms of understanding who's in the sample, I'll look at this first column. So again, in the Medicaid-only group, they were about half non-Hispanic white, 20% Hispanic, and almost 20% non-Hispanic Black, with smaller groups of Asian and then other. The age range was relatively spread out, with the biggest number in the 55 to 64 group, almost 40% there, but everybody from under 44 to over 85 as well. The Medicaid-only group was about half female versus male, and we didn't have any other gender categories that are collected in this data. And then in terms of the qualifying diagnoses, so again, people had to have at least one of these, but they could have more. The most prevalent one in the Medicaid-only group was heart disease. Over half had heart disease. Over a third also had dementia. May have had both, or maybe just one or the other. And then smaller numbers for the other 3. And looking here at the number of diagnoses, we also looked at that. So again, in this Medicaid-only group, almost 3/4 just had one diagnosis, one of the qualifying diagnoses. And the last thing to point out here is that about 35% did have experience in a nursing facility within 60 days before death. So the next slide shows similar numbers, but for the Medicare dually eligible population. This is a much larger group. So remember, the other is a little under 5,000, and here we have almost 24,000. So most of the decedents in this total Medicaid sample were also dually eligible. And here we see the higher number for use of hospice. I'm trying to get my pointer. Where did it go? There it is. So almost half of this group of decedents used hospice. But the short length of stay is 40%, almost identical to what it was for the Medicaid-only group. The much higher percentage in this group is white, almost 80%. And not surprisingly, because Medicare is primarily for older adults, there are the largest, the preponderance of age groups are over half or over 85, and another quarter between 75 and 84. Not surprising, but there are younger people as well in this dual group. In this duals group, almost 2/3 were female, and in terms of the qualifying diagnoses, dementia and heart disease were prevalent in more than 2/3 of the sample, both of them. And here we also see a much larger percent who had more than one qualifying diagnosis compared to the Medicaid-only group, which had about 3/4 only had one qualifying diagnosis. So the samples these two groups are certainly different, as you would expect. Here we also see that a little over half had some experience in a nursing facility in the 60 days before they died. One of the main focuses of the paper was trying to look at the different use and different outcomes by race and ethnicity. So this is the bivariate analysis again, but just to try to show you in a more graphic way, in a picture, sometimes it's easier or more impactful than looking at numbers in a chart, so in a table. So here we have our two hospice outcomes on the left. These are people, whether or not they received hospice care at all. And then among those who did, on the right, hospice recipients who had short hospice length of stay. And the difference, there are statistically significant differences for the Medicaid-only group in both of the hospice outcomes, and for the dually eligible group only in receiving hospice care or not. There was not a difference in the dually eligible group for whether or not they received a short hospice stay or had a short hospice stay. And so we can see here, remember that the non-Hispanic Asian group was quite small, but they actually had the highest rate of use of hospice among the Medicaid-only group, followed by the non-Hispanic white group. And in the dually eligible group, non-Hispanic white had the highest use of hospice. Black and Hispanic had the lowest use. So we definitely see some significant differences in terms of access in both groups, in terms of access or use of hospice. And then here with the short hospice stay among those who do use it, we see especially the other and the Hispanic populations had shorter hospice, were more likely to have a short hospice stay. And this is the Black group here in the middle. So the versus the white or the Asian group were less likely to have that short hospice stay. So we're seeing differences in access by race and ethnicity. So the next two slides summarize the results of the logistic regression, and again, trying to show it in a graphic way rather than in a table. These are logistic regressions. So the odds ratios are the blue dots, and the confidence intervals are the lines. And any line that does not cross 0 is statistically, or sorry, does not cross 1. This dotted line here is statistically significant. And so here we're looking at the Medicaid-only population again. I should have mentioned earlier the reason for looking at Medicaid-only by themselves and the dual population by themselves is because of all the significant differences between those populations, which we saw in the first two slides, especially the age groups. So we wanted to use different age comparison categories in these analyses, but also looking for, our patterns of use and patterns of length of stay just completely different in the Medicaid-only, like what factors are important for this group versus the duals group, and that's why we have the separate models. So again, for Medicaid-only, looking at any hospice use outcome, this similar findings as what we saw in the unadjusted analyses. These are now adjusted for all the other things in the model. We still see the Hispanic and non-Hispanic Black having lower likelihood than the reference group, which is non-Hispanic White. In terms of use of hospice, the higher age groups are significantly more likely to use hospice in this group, and women are significantly more likely than men to use hospice, and those who had a nursing facility stay were more likely to use hospice in this Medicaid-only group. Keep that in mind when I flip to the next slide, which shows the opposite effect actually for the duals. In terms of the short hospice length of stay, Hispanic population and the other race category were more than twice as likely to have a short length of stay compared to non-Hispanic White. There wasn't really an age difference here in terms of length of stay. Women were less likely to have a short length of stay, and the nursing facility didn't affect the length of stay here. So we'll turn now to the similar slide, but for the dual eligible group, and we see some similar findings. So again, Hispanic, non-Hispanic Black are less likely to use hospice than non-Hispanic White. As age goes up in this dual eligible group, we see a much stronger likelihood of using hospice. So by the time you're 85 or over, 3 times as likely to use hospice as a younger group was with Medicare and Medicaid. Women more likely than men, as before. And as I mentioned, the nursing facility effect is reversed here for the dually eligible, where those who had nursing facility use within 60 days of death were almost just over half as likely to use hospice. So there's something going on in this nursing home use that deserves further exploration. And then the last outcome for this group, short hospice length of stay. Again, Hispanic is consistently across all these models more likely to have a short length of stay if they do use hospice. Here we do see in the dual eligible group, we also see an age effect for a short length of stay, where the old people in the older age groups are less likely to have the short length of stay. So older groups are more likely to have a medium or longer length of stay, which is the quality measure. And then women less likely than men to have a short length of stay. And here again, among those nursing facility users in the dual group, they are also almost 3 times as likely to have a short length of stay. Okay, so I've shown you a lot of numbers and figures and kind of contrasting different groups that you can't necessarily see side by side. So I'm going to try to summarize the results a bit here and kind of pull out the most important things that we think need further exploration, further research, and further discussion. The dual eligible decedents, so 49% of those were much more likely to use hospice than the Medicaid-only group. So even though we did our best to kind of, I won't say equalize the sample because it's not propensity scored matching or anything kind of statistically we didn't statistically control for or try to make the groups matchable but or comparable, but we did use the hospice eligible diagnoses as a way to try to just identify groups that we knew would be different in terms of age and other things, but try to make them sort of similar in their likelihood of hospice being a reasonable thing that they might have been eligible for, or might have been recommended for them. So again, the dually eligible group were more likely to use hospice than the Medicaid-only group, but 40% of both groups were in that low, short length of stay category. So any hospice use was more likely for kind of across all models for older people and for female decedents. We did see variation by race, depending on which insurance group we were looking at. So for the dual eligibles, non-Hispanic, Black, Hispanic, and non-Hispanic Asian decedents had lower odds of using hospice compared to non-Hispanic white. The Medicaid-only group, that was restricted to Hispanic and non-Hispanic Black, so similar but not exactly the same. And then we found higher odds of short length of stay in hospice, which is again a marker of poor quality, specifically for the Medicaid-only group, among Hispanic decedents, and then among the dual eligible group for younger and male decedents, as well as nursing facility residents. So this slide is really trying to think more about, what is the big picture? What are the implications of these findings in this analysis? We see here that the population that's insured that only has access to Medicaid is, again, much less likely than those who are dually eligible to use hospice. So knowing about how to access or acceptability of hospice may be a bigger issue for this Medicaid-only population. We don't know why this is true, but we can speculate based on other research for things that predict more or less hospice use in other populations. Again, access or acceptability are things that other researchers have identified as challenges or barriers to using hospice. And we saw here, even despite similar diagnoses, that age remains a strong predictor of hospice use in both insurance groups. So that it's possible, maybe we can speculate that maybe providers are more apt to refer women or more apt to refer older people to hospice. That could be going on. Possibly older people who have a chronic illness compared to younger people who have a chronic illness, or women are more likely to desire or be interested in or agree to hospice care if it is recommended. So we don't know where the differences are happening kind of along the spectrum of interaction with the healthcare system. But our findings definitely raise concern about equity of access to hospice and to palliative care more broadly across these different groups. So age, sex, race, there are definitely differences here that should be explored more. And then other research has pointed to other confounding issues such as spiritual or religious beliefs and trust of the healthcare system or trust of providers, as well as looking at the provider side, maybe provider familiarity or comfort with end-of-life care and hospice and how to integrate people. And we're doing some more active work and actually have a subsequent smaller grant from a foundation to look more into the nursing home findings that we saw here. It's particularly interesting that they were different for the Medicaid only versus the dual group, but in general, seeing definitely an effect of, if you have nursing home experience, that affects your likelihood of having hospice or the length of time that you spend in hospice, and trying to figure out more about why that's happening and if there's an intervention point there. And then we definitely recommend more research and then intervention development around improving hospice use, particularly for younger people, as well as men and non-white populations, particularly with Medicaid. So this is one of the first studies that's really focused on a Medicaid population and their use of hospice, and things that may or may not improve that. I did mention these limitations as we went through, but just to circle back to them. So we did not have Medicare Advantage data in this data set that we had access to. So we knew who had Medicare Advantage, but for those who had it, we don't have the encounter data. So we don't know for them like what their hospice use is or what their diagnoses are. So we had to exclude everyone who had Medicare Advantage at any point during the 12 months before death. Medicare Advantage had kind of historically not been used much for hospice. It was sort of a carve out, but that has changed over the past several years. And so it's really important to get access to that Medicare Advantage data and look at these issues inclusive of that population as well. And there is some work in that area from other researchers. And then just the limitations on the race and ethnicity data. Connecticut, and it's not actually limited to Connecticut, and we have historically really poor quality race and ethnicity data. So we tried to construct this data using available multiple sources to improve the quality and accuracy of that data. And that's the end. So here's my contact information, and be happy to entertain questions. I can leave the slides up if we want to refer back to anything, or I could take them off so everybody can see each other. Into suggestions on that.
Whichever you prefer, and of course, open it up for questions too, if any are related, wanting to go back to certain slides, please feel free to ask.
I guess I can ask if there are any clarifications or any slides that anybody wanted to revisit, and then if not, I can go ahead, Judith.
Yeah, and the whole thing is very interesting to me, but one of the things that I noticed that I was really surprised by, and it does maybe mean going back to your earlier slides with the diagnoses as part of the bigger analysis at the beginning, the numbers, the percentage on cancer was 6% for those who used hospice for the Medicaid-Only, and 12% for those who were dual. And just as somebody who spent a lot of years doing hospice, I was really surprised by how low those numbers are. And I know that isn't the focus of the study, but I'm really curious what you think of that. It just is really a surprising finding to me.
Yeah, it's interesting, isn't it? I mean, I think from the Medicaid-only participants, they are a younger group, but we do see a high percentage of people with dementia there. So we only looked at the 4 or 5. Let me just go back to this slide here that shows the diagnosis. So we didn't look at any cancer because, you know, some cancers you obviously can live with for a long time, and we were trying to look at people who might be closer to hospice. So it may be that because we limited the types of cancer to those that, you know, in the hospice literature are pointed to as if you have one of these types of cancer, then, you know, hospice is more likely. So that may be part of it, but it is low, particularly in the Medicaid-only group of 6%. Yeah, it's an interesting point. Go ahead, Stephen. Stephen, yeah.
Yeah, hi, thanks. Very interesting. Something that's on the minds of a lot of us who are interested in dual eligibles and in Medicare is what is your thinking about how you might develop research strategies to incorporate the Medicare Advantage? You know, the Medicare Advantage has become so important that many of us, and you know, we're kind of the same, who historically did a lot of work on the fee-for-service population because of the data issues. But now with the increasing proportion of people being, and in fact, for example, minorities, low-income people being heavily recruited into Medicare Advantage, Medicare, and we know that Medicare Advantage is sort of has a direct financial. On the one hand, they have sort of maybe more mechanisms for identifying people in need of services. On the other hand, they have sort of a direct financial incentive to when they provide less, they make more. Hospice is slight exception to that problem, that issue, because of carve-outs. But in general, what's your thinking about? I mean, would that require going to the VRDC, for example, for your line of research?
Yeah, so this data, and this might get a little more technical than what you even need to know, but this data is from the State Data Resource Center. So the states have access to data through SDRC, and for whatever reason, SDRC does not have access to Medicare Advantage data. So just on the technical level, if we wanted to get access to SDRC, to Medicare Advantage data, we couldn't even just access the Medicare Advantage data and pull it in to match it with this data. You're not allowed to do that kind of thing. So yeah, so we would have to go either to VDRC. There have been, there are certain, CMS has concerns about data kind of floating around out there. So they're proposing new rules to restrict access to provide kind of hard copies of data sets to researchers. Remains to be seen what they'll be saying to states about that. We actually have a subcontract from the state of Connecticut, which is why we have access to this data. So in terms of access to Medicare Advantage data, it's a lot of hoops. We're still trying to navigate which hoop we might be able to jump through, but I think it really depends on kind of whether, for us, again, working with the state of Connecticut, we're trying to use that as a tunnel, but not successfully at all to get access.
It's an interesting time,
data.
However, for these state integrated databases, and we have a similar one in that the Institute operates on behalf of the state, the Integration Integrated Population Health Database, and that is moving very slowly but steadily towards getting all the agreements to incorporate Medicaid and so forth. But the interesting legal angle that has just come up, it's rather complicated at the moment, but with CMS's new initiatives, is that there's a different category for states that get CMS data, even for even for research purposes, for integrated databases, because they come under, and you get some hints from the things that CMS has been saying, that they may in the future be willing to give physical data, more willing to give physical data to states that are sort of overseeing any use of it, let's say by university researchers, than to the universities directly.
Right. Yeah. And there's a cost or not a cost. It could be a really big cost if you need to pay for it. So that's a whole issue. I know that there's some CMS has taken a little bit of a step back, is what I've been hearing from their plan to just kind of categorically make those rules, and considering some of the things that have been brought to their attention by researchers and by states as to how, what impact the changes in those rules would have. But also they are responsible for protecting really sensitive data for huge amounts of people. Hey, Olga. So it's not unreasonable for CMS to be thinking about rules, but they might have to be a little more nuanced. But in any case, so even people that, and I think actually Olga, it's too bad she has to leave, because I know that she, I believe, does have Medicare Advantage data that she's looked at in this space. But the quality of Medicare Advantage data is challenging once you even cross all those bridges to get to it, and it's not complete, and it's very opaque. So
it's very hard to find current
but
data on the quality of the CMS Medicare Advantage encounter data.
Yeah, they just don't have a lot of leverage. That those are held.
Well, they have leverage, like CMS with Medicaid, they have leverage if they choose to use it.
Right.
These companies are completely dependent on Medicare for I don't think CMS has been in the space of saying, well, you know, we'll knock off 5% if we're not getting clean data from you because you're not able to show us that you're
Yeah.
providing the services that you're getting paid to provide. But
Yeah.
I haven't, you know, they have some mechanisms to do that. I'm sure that's also a complicated legal issue as well, but it's more
Yeah,
a political
like a
issue. You know, you're
contract
talking
and-
about some of the most powerful corporations in America. I was just reading this thing about United Health, which people are starting to focus in on. You know, United Health is the fourth biggest, you know, people don't think of United Health as being in the same sort of category as Amazon, but it's become one of the four biggest and therefore most politically powerful corporations in America.
Absolutely, and they're
That's the
everywhere.
reality of this.
Yeah, it's hard to follow those paths. Yeah, so so it's very important to get Medicare Advantage data, and the path forward is not easy. So it's a big limitation for sure. Yeah.
Hi,
Dawn.
Julie. My
Yeah.
name is Dawn. I have a quick clarifying question.
Sure.
So you have to meet certain criteria to benefit from receive the Medicare hospice benefits, and and also I think it's the trend. There is a changing trend, but you also have some limitations to curative care once you opt for hospice care. I was wondering about the how Medicaid hospice benefits are pretty similar or equivalent to Medicare hospice benefits.
Yeah, that's a really good question. So you may have heard the saying of, you are familiar with one Medicaid program. That means you're familiar with one Medicaid program, because they really vary enormously state by state. So I can speak to the Connecticut benefit, Medicaid benefit, which is modeled on the Medicare benefit. Except that those criteria, those strict criteria for, you know, the 6-month expected life expectancy, that is a little bit more relaxed in the Connecticut Medicaid benefit. Connecticut was one of the last 2 states to actually develop a Medicaid hospice benefit, but it has been in place for, I can't remember what year it was, but 10 or 15 years already. So it's not new, maybe longer, but it was kind of late to the table to add hospice to Medicaid, but they did model it on the Medicare benefits. So
pretty similar.
Yeah, they're very similar, but that is not true in all states. Now, the Medicaid benefit can be much more restrictive in some states than Medicare.
Okay. So maybe knowing that it has less strict and more generous criteria in terms of the life expectancy, and your research showing the underutilization of hospice within Medicaid population, it might be more telling us that we need to more study about the access issue within the population.
Yeah, exactly. Yeah. And it's hard to disentangle all of these different things that, you know, like the differences between the Medicaid-only population and Medicare duals population those are structural, right? So those are not going to go away. It's hard to explain those away statistically, and we didn't really even want to try to. But even with, you know, even as we, you know, at least in our adjusted model, we still found those really strong differences, despite trying to have similar criteria for being in the data set at all. If you don't have specific more questions, I just wanted to say a word about the publication process for this paper, because it was, and I'm not sure what everybody's affiliation is, if most of you are in academic settings or doing, you know, research and publication, but I'm assuming so. So this was the first time that I had published a paper with JAMA Health Forum. That's an open access journal, and which is great. So, you know, anybody can have access to this. It's obviously a highly respected one, not a concern that there might be kind of some, you know, the predatory journal concerns are not don't apply to JAMA Health Forum. And it's a relatively new journal. I can't remember how many years, but they were very, very fast, very, very responsive. They get a ton of submissions. And as Kylie mentioned, I just stepped down as being the editor of the Journal of Applied Gerontology, which is not an open access journal, but have some experience, on the editorial side. I just did that for 6 years. So it was overall a really great experience, with a caveat, which was that there were mistakes printed a couple of times, and we had to go through 2 rounds of post-publication corrections. One of which was found by a reader, and he wrote and he said, "I just don't think this odds ratio makes sense at all." And I looked in the table, and they had moved a decimal point after we had approved the proofs. So it was, and I think it was strange for them too, because then they were coming back and they were saying, "We don't understand how this happens." But anyway, so, and that's not to pick on JAMA Health Forum at all, but just as, a publication experience that they wanted to make additional changes after after we had approved the proofs. But in the proofs, how you get proofs back, and they're usually very small editorial things, but they wanted to add a bunch of stuff to the abstract. And so
they're mimicking Health Affairs.
Yeah, I guess
Health
maybe.
Affairs is historically the most notorious journal for wanting to do that. They'll change your title, they'll change your abstract.
Yeah.
And
Yeah.
I think there's a similar perhaps psychology in mind, because those 2 journals that want to speak to health policy
Right. They want to
want
grab
a broader audience than
Right.
just academics.
Yeah, and that
They want
I
to be
don't
read
mind
on Air
that.
Force One.
Yeah, right. And I don't mind that. I've had that experience with Health Affairs too. It was just when it happened. So I didn't feel like they should have accepted a final version and said, "Okay, this is accepted, and here are your page proofs. And by the way, we want you to add a whole bunch of new numbers and different things to the abstract," because at that point, the proofing process fell apart. So we found a couple errors right when it first came out, not because we hadn't seen the proof of the proof after we had made the additional changes that they wanted to see. And then after that, we had a reader identify another thing that was in the table that was correct in the original proof that we sent. And then in the changes they made, they moved it, but we didn't notice because we didn't know they were. Anyway, so just a lesson to, review your proofs and make sure they don't make any changes after that of substance. So if you download this article, or if you want to share this article, please download the current version. If just by chance, if you had seen it in December and you were excited about it and you were sharing it, go back and get the current version, because there have been some corrections as late as March.
That's great. I think you still probably made a wise choice to go in that direction for a broader audience, having been on the GSA publication committee at different times. GSA tries to exercise quality control, as you know.
Sure.
And that's sort of in a sense the advantage of these professional society ones. But JAMA is running a big business.
Absolutely, and it's very visible. And I will credit Brad Richards for suggesting JAMA Health Forum as the place to publish this. We as a writing group were sort of trying to get outside of the GSA journals, and I publish in a lot of different places, but I'm always looking for a different audience that might not have seen this whatever piece of work I'm doing. So Brad was the one who suggested it, and overall it was a great experience, except for that last a couple of things. I would
guess, by the way, that John Ayanian would be very embarrassed that something like this happens, because this is what this is like. Things growing so fast,
right? And he didn't get involved at this stage,
managed.
but he was involved in the very beginning, and we wrote to him and said, "Do you think this is a good fit?" And he said yes, and that whole thing. I think it may have just been whatever managing editor was assigned just didn't have the correct order of things. They should have just said, "We need you to make some more revisions before we accept this," and send it off to India or wherever does the production.
But it's always interesting for all of us to keep up with the evolving journal landscape.
Right.
I I would guess, I'm probably not a very good futurist, but I would guess that within a few years, NIH is going to bite the bullet and say, here's this fund. It operates out of, they've done this, like they were doing it with data access for a while, with access to NDI. And they've done things like this. Well, we'll have a separate pot of money. And when you get a paper published by one of the top open access journals, then we'll pay, or they can just build it into the grant. But then, of course, you need that money for multiple purposes. So I think that's the solution, the real solution. The whole business of the requirement to publicly post papers within 1 year. Number one, there's still that 1 year lag.
Right.
And it's, the whole thing is a little bit dubious in terms of copyright law. So the solution,
and which version is posted, and it's there might be differences in it. Yeah. Well,
so the solution is to go to all open access.
Yeah, I agree. And how to get to that spot is a bit tough. And from a journal editor who was not open access, although any particular article could be made open access with a fee, it's an interesting place. I agree with you that I think open access, I think a lot of the journals are going to be switching to that who aren't right now. And I do now regularly include in grant budgets publication costs, which is very helpful. And it also allows me to support students in publishing. Two more things about that. One is that you're often publishing articles after the grant is technically over, and then you don't have access to the funds anymore. So unless you can move them over to an institutional fund, some funders will allow you to do that, but most won't. You kind of lose that unless you're publishing during the active time of the grant. A lot of journals, open access journals, also have hardship, waivers. So if you're a student, almost always that will qualify for a hardship waiver, and they don't always call them that, but basically they'll waive the cost of publication if you say, I don't have a source, or they'll vastly reduce it. So that's definitely something to ask for if you don't have.
But if you go back to what should be the ethical contract between the researchers, the universities, the journals, and the public, everything should be published open access immediately, because it is crazy to spend $40 billion for the NIH and then not have that's the public's knowledge. It's not some private publisher's knowledge. It's the public's knowledge.
And then what's the venue for publishing? Because that's a business, and they have to pay salaries, and there are costs of publishing for sure. So if you're not charging subscribers,
it's the responsibility of the NIH to pay for it separately. They just have to bite the bullet and do it.
Yeah. So anyway, yeah. Well, thanks for your input, both on the paper itself, but also on the the wraparound pieces.
Oh, you've won high praise from Elizabeth. I think a lot of other people have, you can tell a lot of other people are excited about this work as well.
Yeah. Well, and I mentioned briefly, but we do have a grant from a Connecticut foundation to try to explore that nursing home piece some more. So we have a 2-year grant to do. We're looking at more detail at the data that we have around nursing home use in different populations, but also to do some qualitative interviews with hospice providers, nursing home providers, the trade organizations in the state, and try to kind of get at a little bit more about what's happening there.
I would just say that one other thing I would say why we think it's so important, and we've run into similar issues in other spaces like opioid use disorder, to really start finding ways to explore the research to manage care, is that's the direction that the system is being pushed in. It's the direction that it's going, and also that when you start identifying equity issues, who's responsible for fixing them? So who could be made a locus of responsibility? Who are you going to develop equity measures and,
Mhm.
and goals and try to enforce them. And fee-for-service is very hard. It's this amorphous system of providers out there. On the other hand, in this increasing world of managed care, including all of the power that's been given to managed care organizations for managing long-term services and supports, they're ultimately going to be the parties that we want to try to have some accountability to.
Yeah. Yeah.
And they
we
have
could build
tools
in
that they
for sure.
could use if they want to. So, you know, we're going to be kind of forced to start looking on the side of the street where we drop the keys and not the side of the street that's under the lamppost.
Yeah, right. I like that analogy. Thank you.
All right, well, we are just at the end of our time. So of course, want to thank everyone for joining today. And of course, Dr. Robison for this great presentation and discussion as well. We really appreciate you sharing this talk and your expertise with the NJX community. So thank you so much. Thank you everyone for joining and take care. We'll see you at the next seminar.
Thanks again for the invitation.